So, welcome to Radcliffe Cardiology. My name is Mamas Mamas. I'm Professor of Cardiology at Keele University in the United Kingdom, and it is my pleasure to introduce the author of one of the most important trials of the European Society of Cardiology, Professor Shamir Mehta from McMaster University in Canada. Welcome, Shamir.
Thank you.
So it's a really important trial, COMPARE trial, looking at patients with multivessel disease in STEMI, complete trial. How important is multivessel disease in patients with STEMI?
It's not uncommon. It happens in 30 to 50% of patients. We see it one out of approximately every 2 to 3 STEMIs will have multivessel disease. And their prognosis is much worse than those with single vessel disease.
Yes. And there have been a number of other randomized controlled trials in this space, much smaller than yours. Perhaps you can tell us something about what their main findings were.
Sure, yeah. So they're generally well-conducted randomized trials, but substantially smaller in size, powered to look mainly at revascularization. And almost uniformly, they've shown reductions in revascularization using various definitions. So what we have not had, though, is a trial showing that complete revascularization impacts hard clinical outcomes such as cardiovascular death or myocardial infarction.
And so you've set out and presented the complete trial. So maybe you can tell us something about the design of the complete trial.
So we designed COMPLETE really to address that evidence gap, to see whether or not complete revascularization reduces hard outcomes, cardiovascular death or myocardial infarction. In order to do that, we needed large patient numbers. So we designed a global study. It involved 31 countries across the world. It involved 4,000 patients. And we randomized them in a one-to-one fashion to receive either a strategy of angiographically guided complete revascularization or a strategy of culprit lesion only revascularization. Importantly, both groups got optimal medical therapy, and that included aspirin, P2Y12 inhibitor, beta blocker, statin, ACE inhibitor. And of the P2Y12 inhibitor, about 3/4 was either ticagrelor or prasugrel.
Yes. And did you require the investigators to undertake complete revascularization at any particular time point?
So the protocol specified they had to do it within 45 days of randomization, and we stratified our randomization according to their intended time. So they were asked before randomization, if this patient is stratified or randomized to non-culprit lesion PCI, when do you intend to do it? During the initial hospitalization or after?
Yes. And for the complete revascularization arm, did you use ischemia-guided, symptom-guided, FFR-guided, or was it just dependent on the severity of angiography?
So the concept was preventive PCI.
Yes.
That was what we wanted to test. So they had to have complete revascularization irrespective of whether they had symptoms or whether there was ischemia on non-invasive testing.
Yes. Wow. And tell us about the results. What were your main findings?
So the follow-up in the trial was a median of 3 years. Longest patient was just over 5-year follow-up. And the first co-primary outcome, which was cardiovascular death or new myocardial infarction, was reduced in the trial by 26%.
Yes.
It was a highly significant reduction with a p-value of 0.004. In the second co-primary outcome, which included ischemia-driven revascularization, was reduced by about 49%. Very consistent with the smaller trials before, showing that reduction in ischemia-driven revascularization. The new finding, obviously, was the reduction in the harder outcomes.
And interestingly, there didn't really seem to be much of a difference as to whether you did the complete revascularization as an inpatient or post-discharge. Did that really surprise you?
So it did, actually, because the conversation up until the time we saw the results of the trial was very much about what is happening during the acute treatment period. Should we be doing them earlier? And then there was a lot of discussion about should we actually be doing it during the same primary PCI procedure. It turns out that at least what we've seen, what we've observed in the trial, is that the main benefit, the main value of a complete revascularization strategy is really over the long term.
Yes.
Within the short term, most events probably are related to the index infarction. We forget these patients have all had a STEMI.
Yes.
Both groups have had a STEMI. patients with STEMI have complications. There's a finite mortality rate. They have heart failure. They have other outcomes related to the index infarctions. It's only beyond that point where over the subsequent 3 to 5 years that we see events occurring more frequently in the culprit-only group than in the complete revascularization group.
So you looked at a number of different secondary subgroups, and one of the very interesting ones to my mind was the LAD, the proximal and mid-LAD subgroup. So what do you think about that?
So we had about 10 to 12% of patients that had true proximal LAD lesions, as outlined in the angiographic core lab. It was overread. So that's about 400 patients. Similar size to some of the smaller trials. And we saw no heterogeneity. So the treatment effect was similar in those with proximal LAD lesions and those without proximal LAD lesions.
Okay, great. And I mean, how does this change practice, do you think? I mean, do you think that there is any role for ischemia testing, FFR testing in these patients?
Well, the concept is very similar, if we go back to stable coronary disease and we look at multivessel disease, the early trials of CABG surgery showed long-term benefits with complete revascularization. Using a different mode, that was using CABG surgery. Here we're using PCI, mainly because the patients present with a critical condition that requires PCI, so they've already started down that route. But now it seems that we're seeing a very similar phenomenon that, over the long term, we're starting to see a benefit of this complete revascularization strategy. So, and we didn't see a major downside in the trial. So our safety outcomes were not statistically different between the two groups, but I should say they were numerically higher in the complete revascularization group. None of them met statistical significance at the level that we had with a sample size of 4,000 patients, but obviously if we had a sample size of 40,000 patients, some of those may have become significant. So, I think that the trial itself suggests that physicians should consider a revascularization strategy. There are options about when to do the non-culprit lesion PCI. It could be acute, but if a patient has comorbidities, contrast-induced nephropathy, if they're frail, if they're elderly, it may be better to let them recover, and then you could always bring them back at a later time point, within the first month and a half or so, and do it then.
Okay. Well, I'd like to thank you for joining us. I think it's really a truly groundbreaking trial. It's something that will impact on our practice, and I think it's going to really produce a guideline change and a sea change in how we treat these patients. So thank you and congratulations.
Thanks for having me. Appreciate it.